who are coming as a SARI cases, that's severe acute respiratory infection, or those who have come in the contact with the COVID positive confirmed cases. It's very important to screen the healthcare workers who are working in your facilities. Most important that the level of testing, the threshold level of testing needs to be low in terms when it comes to the healthcare workers. So that's an important part which everybody should, make a note of it. Sometimes we may be little tied up by the guidelines, but it is always good to, keep a threshold level little low for the healthcare workers who are working in the healthcare facilities. Second, we need to segregate the areas where the triaging has been done. For example, for the walk-in patients in your OPD, you can have a separate triaging area where you have a checklist of 5 or points which are there in the testing guidelines, whether they're coming from a hotspot region, the history of fever, cough, shortness of breath, so they can be preliminary screened. And then they can be subsequently taken up to the other OPDs. If they are fitting into certain category that which require testing, then they should be taken up for testing. I would suggest that for emergency, you also need to have a triage screening area where all the patients who are coming to the emergency should be screened first for COVID-19. And if required, they should be tested. The most important part is that you need to develop a holding area in your hospital where such suspected patients need to be kept for the time being till the results are made. So that can be a separate area where such kind of patients are fitting into your suspected COVID-19 cases, they can be kept there. And this area needs to have a proper ventilation. The staff who are working over there need to be in proper PPs, which needs to be provided by the hospital, and the waste which is being generated needs to be handled properly. The most important thing is that the turnover time of your testing will determine that how many patients you are holding in your areas. Right? I believe that answer your questions, or there's something else which you want me to add?
No, that's fine. I mean, the audience is here, and if they have more questions, we will open it up in the open session. My second question to you is, it is open knowledge that there is dearth of negative pressure operation theaters and intensive care units, even in the biggest hospitals in the country. So
yes,
of negative pressure OTs and ICUs, what is the next best solution?
See, the most of the air conditioning, most of the hospitals are having a central air conditioning system. So I'll just like to tell you a little bit about the central air conditioning system, how it functions. There's an air handling unit, which is called the AHU, which is installed at the ward level, or it can be at the ICU level and at the OT level. So ideally, each ICU needs to have a separate air handling unit. That means it handles the air from that particular area. Similarly, each operating room need to have a separate air handling unit. And when we say about the negative pressure, what we mean to really focus on that area should be relatively negative pressure from the other area, so that you are not spreading the infection to the other side. So to be honest, if you have an existing air handling unit in your hospitals, these are some sort of a customized air handling units. They have a certain load design considering the fact where the air needs to be recirculated, or it needs to be 100% fresh air. So I don't think it would be appropriate to say that we can convert the recirculating kind of AHUs into 100% fresh air. But most of the modern facilities which are being developed over past 5 or 10 years, they have 100% fresh air in their operation theaters with ducted returns. So and they have got an inbuilt HEPA filters, pre-filters, which take care of that part of it. So if you have 100% fresh air in the operation room and relatively negative pressure, because usually the operation theaters are positively pressured compared to the other areas in the hospital. So you have to reduce the volume of air which is coming into your OT. So in the existing system, it will be a little tricky thing. So you need to consult the design engineer who has installed your air handling unit, and maybe it needs to be worked on a side to side basis. But the most important part is it has to be relatively negative pressure compared to the other surroundings. 100% fresh air with ducted return, which is there in most of the modern facilities or the private setups or the government setups also, I would say. Most of the places, the modern facilities which have been built in, the ICUs also have 100% fresh air. And if you have isolated cubicles, if you can somehow, you have some facility in your hospital, it can be a bone marrow transplant unit, which may not be that much functional. So they do have a proper kind of, ducted return system with laminar flow. So all those kind. So you need to identify such facilities where you have this kind of a setting. Relatively negative air, relatively negatively pressurized compared to the other areas, having a flow of 100% fresh air, ducted return. So these are the 2-3 things which needs to be there in the facility.
Thank you very much, Dr. Vijaydeep. I take the opportunity to bring my second panelist here. Dr. Yogiraj Roy is an assistant professor in the School of Tropical Medicine. Dr. Yogiraj is very actively involved in hospital infection controls, currently in two of the most high in the state, the ID hospital in Belghata and MR Bangur. Welcome, Dr. Yogiraj. And my question to you is, since you deal with infection control, you are an expert in this thing, how to protect our healthcare personnel through effective infection control strategies when they are working in COVID areas. And I also want you to speak a bit about the biomedical waste management.
Hello, good afternoon. Actually, I came in West Bengal from AIMS, from Dr. Vijaydeep's institute just 2 months back. I knew him very well. The problem is working here is that you are in the middle of nowhere, and nothing is there where you can think that you can change anything to a negative pressure or positive pressure or any pressure. So what we try to make the best of it, that what we can do with the existing scenario. When I started working in after coming first COVID positive patient, and the health department called me to the ID and BG hospital. That is only at that time the only hospital designated for COVID care. So we designated the part separately for the COVID patients, and there are cabins, 12 cabins we had at that time, and all of these are actually having HEPA filter. But there was no typical negative pressure type of thing. So what we have done, that we designated the doffing and donning areas specifically, and restricted the entry of common people over there, and we make a register so that who are coming there and going out from there has to be we know that who are there going inside and going outside. And thereafter we trained all healthcare professionals about donning and doffing and other things, and hand hygiene specifically, and we started to work inside the ward with PPEs and N95 mask. And for last 1.5 months or around 2 months, we have COVID over there, and not a single person got infected amongst us till now. So what we do, that we should work inside that ward with PPEs and N95 mask, and we follow the hand hygiene very strictly. So I am not only the actually I am a DMID from AIMS. I'm not only the person looking after of these infection control part, there are other microbiology people also. So we made a team who will go give round every 2 hours interval, and will just overview whether everybody is doing their work with as per the norms or not. So we made a checklist, and we tried to involve nurses also in this work, and they are checking us, we are cross checking them. Like in this way, um, till now we are not infected, not a single person. Then we started another 2 wards because cases are increasing. So we started another 2 wards. That was actually an open ward. So we changed it to air conditioned, because with PPE is very difficult to work in without air condition for more than 6 hours like that. So we converted it to split air condition, not central air condition. And but our government was not able to give us HEPA filter. So what we tried, to give the spaces of the beds around 2 meter difference of each beds. And we started to have that checklist and the registration thing. And every 2 hourly, our various cross-checking people will cross-check whether we are doing it right or not. And as per that, marks has been given to all of us, whether you are performing well or not. So if they are not performing well, we arrange a session for them. Say if I get 5 out of 10, then I will have to have a session for that. So that was mandatory in ID and BG. In currently, what SAT told, that we in all possible areas of central air condition, we can go with that system. So we actually, when we started working in MR Bangur, when I came here, we found that there are some areas where central air condition kind of things are going on, and how many air exchanges over are happening over the hour is not clear over there. I discussed with the um, engineers, then taken aback what you are telling, what are the air exchanges, I don't know. Like so we cut off this kind of air exchange, we cut off the central air condition, and we open the windows, and given large pedestal fans, so that the negative some sort of negative pressure is there. But in MR Bangur is a big hospital, and it's not possible to have air condition right now. So where right now I am working is without air condition, with PPE and N95 mask and hand hygiene. So I personally tried that the best thing we can do, that we can wear N95 mask, we can have PPE, and have the hand hygiene regularly, cross-checking of these things and checklist. The donning and doffing area, what I tried, there was multiple donning and doffing area in MR Bangur hospital. So I closed all this. I have started one donning area in the entrance and one doffing area in the exit with a shower facility. So that I've started. And last 3 weeks in this hospital, there was no COVID positive amongst the healthcare worker with this kind of protocol. And what we tried, that we always insisted that supply of PPE and N95 mask and gloves should be there. And we constantly poking our DME and DHS for that also. So they are tired of my phone, so that no, there is no PPE. Actually, I and my team usually see it as around 500 PPE should be there in any COVID hospital uh, in our supply. If we don't have that supply of 500, less than 500, we try to poke our seniors to give us PPEs as if there is no PPE. So this sort of thing, and government of West Bengal is still now helping us in this
Thank you.
regard.
Thank you, Dr. Yogiraj. that was almost a very first-hand experience of how the government and COVID warriors like you are fighting at the forefront of this pandemic. And we are getting a lot of very informative inputs from our seniors. Dr. Murlidhar Kanchi has written about switching off of the air conditioners and how negative pressures can be done. I also am getting other comments. We won't have time for that. If we have some time at the end, we might discuss a few of these inputs coming from the senior faculty. We won't have time for an open session here because both of our faculty in the first session have taken time to nicely answer their questions. So I will straight away jump to the second session to keep on time. And I'm inviting now Professor Choitali Sen.
Dr. Rahul, can I make one quick point?
Yeah, Dr. Vijay, please.
It's regarding the biomedical waste. I believe Dr. Yogiraj forgot to mention about the biomedical waste. So the most important thing in the handling of biomedical waste is that you need to have proper segregation in the doffing areas where you are generating the biomedical waste, and it has to be secured, double bagged, labeled as COVID-19 waste, and the healthcare worker who is carrying this waste needs to be donning proper PPEs because he will be handling this very infectious waste. And so it should be kept for as much as less time possible in the hospital. These CBWTF facilities in the respective regions they can coordinate and they can immediately take that waste to their treatment facility. So this was the one quick point I wanted to make with regards to the biomedical waste.
Thank you. Thank you.
Sir, one point, Vijay sir, are you recommending all biomedical waste in the yellow bags here?
No, we are not recommending that. In fact, this is a confusion which is persisting at many places that the people, the segregation has to be as per the existing biomedical waste rules 2016. There is no change in that, and there is no change in the method of disposal. Right.
Okay, thank you. I just want to inform all of you attending today's CME that currently there are 60 people, including the faculty, who have logged in to listen to our program. And if this was being done in a hotel like we usually do, the entire hall would by now have been filled up to enjoy this very informative session. And I'm pretty sure as the evening goes by, more and more people will drop it. I will now invite Professor Choitali Sen. Choitali Di needs no introduction among us cardiac anesthetists, but for people who are joining from outside, she is the head of the Department of Cardiac Anesthesia in SSKM and IPGMER Hospital. Choitali Di, my first question to you is regarding the ICMR testing guideline. We see that the ICMR keeps on changing the version. I think the last one was on April 16th, as far as I remember. On whom to test as infections start getting detected in hotspots and clusters, we see the ICMR is changing the definition of testing. Do you think that the most current version of the ICMR testing guideline will be able to detect all suspects, or some more clauses need to be added? You need to unmute yourself, Choitali. Choitali Di, you have to unmute yourself. We can't hear you. Dr. Ashok, can you unmute Dr. Choitali?
Hello. Dr. Choitali has joined with some other name probably, so I'm not able to find her name.
Galaxy A80. Huh? Galaxy A80.
Just wait.
Yeah, sure.
Yes, I have done it.
No, it is still muted.
Can you hear me now?
Yes.
Can you hear me?
Perfect.
Yes.
Please go on, Choitali.
Can you hear me now?
Yes, we can hear.
Okay. The guideline which says now is all asymptomatic individuals who has undergone international travel for last 14 days. All asymptomatic contact of laboratory contact cases, all symptomatic healthcare workers, all patients with SARI or ILI, influenza-like symptom, Asymptomatic, direct and high risk contact of confirmed case once between 5 to 14 days of coming into contact, and all symptomatic ILI, that is influenza-like symptom if it is there with fever, cough, sore throat and running nose, and within 7 days of illness with RT-PCR, and after 7 days of illness antibody test may be done because it becomes positive after 7 days, and if negative then also an RT-PCR to be done. And regarding sample collection, they say that appropriate biosafety precaution to be taken or separate sample collection site to be there. Sample may be collected at the home if feasible, and it should be done at home. Only RT-PCR should be done and not antibody or antigen testing should be done. The kit must be FDA approved or European certified. Nucleic acid extraction kit and other reagents should be of standard quality. All staff involved should be properly trained, and biometric disposal item to be maintained. And sample to be opened in the biosafety cabinet area. After everything is done, it should be disposed in biohazard bag. It should be sealed and tagged and disposed as per national guideline. Government ID to be given to person's ID and address. All COVID positive samples to be sent to IC, NIV, Pune, and negative to be destroyed. And reporting here in Kolkata, it is done to Shastra Bhavan portal. The result is displayed, and from there to ICMR portal, and the result is directly shown to the MSVP or the hospital in charge. And these are the things being done here. And if you ask me if I am to say my opinion, I don't think that this is the actual way. This should be much more elaborative regarding the hotspot area and all this. And now we are not going to do the antibody testing and antigen testing because the kits has been withdrawn from the market. That is the main issue. And apart from that, WHO was not going to recommend this antibody and antigen testing. They were always with the RT-PCR testing. So we have to do, and some test should come which can give the result within a few minutes. That's, I think.
Thank you, Choitali. You raised one issue, and I want to raise this point here regarding the real life challenges of testing COVID patients in West Bengal. Do you think that there are bottlenecks when we are testing patients for COVID, and how can we overcome them? How can we overcome the bottlenecks in testing?
The first bottleneck is the time of testing.
Choitali, we can't hear you.
It's 6 hours. So what's the utility? You have to do some testing. Can you hear me?
Now it is clear. If you
Can
could
you hear me now?
Yes. If you could repeat your last two sentences.
Okay. Actually, what I think, the government has withdrawn the antibody and antigen testing. Rapid testing has been withdrawn by the government. The result used to come within 30 minutes, but now RT-PCR testing, the result comes after 3 to 4 hours. And mainly, but the centers take some more hours because they assemble and they do the test and they report. That takes nearly 6 to 8 hours. So it is the main bottleneck of testing. If we want to do it in the OPD basis, or if we want to do in a general way, then the time factor is a very big factor, number one. Number two is cost. It takes nearly 4,500 rupees. It has been cut down recently, but the cost is there. Number two. Number three is our population, that is 130 crores. So to take the testing should be done to all the whole of the population, but it is not possible in this way because it takes lots of time, it takes lots of laboratory, and it takes also lots of manpower and everything. So the bottlenecks are here: the cost, the manpower, and the distribution also.
Thank you so much, Choitali, for explaining it very clearly. I can find a very interesting question from Dipanjan Chatterjee. He's the consultant in Medica in cardiac anesthesia. And Dipanjan wants to ask you, is PCR testing allowed on a OPD basis, or is there a plan for allowing PCR on a OPD basis?
Yes, the plan was to do the PCR in the OT patients. In OPD, it is not possible. How much time you can make a patient waiting in the OPD? 6 to 8 hours, the patient will wait for you, and then he will come to you to see you. It is not feasible in our setup. For that, there must be some rapid testing, which is not permitted by WHO at present. That's why Government of India has taken the kits from here, okay? And after 6 to 8 hours, if you get the result, how can we say that after 6 to 8 hours, after waiting for 6 to 8 hours, the patient will come to us to see us? It is not possible. We were trying to here for cardiac surgery. We were planning to do this before cardiac surgery, before elective surgery. But government has told few days back that we can do it preoperatively for all patients. But day before yesterday, there was another circular saying that it should not be done for all cases. If the patient comes only from the area where if the patient comes from red area or red zone, or the patient comes from any contact, patient has history of any contact or history of travel, then and then only, or the patient is symptomatic, then and then only we can do the RT-PCR for preoperative patients. And suppose in case of preoperative patient, we can send the sample, we can take a pooled sample and we can send it for pooled sample. And if the pooled sample is positive, we can do individual testing. If it is negative, then we can take that all the patients are negative. But if the government does not want, then we cannot do that also. Okay. There is clear guideline from government that we can do the RT-PCR for these patients only who are contacts, who has traveled abroad, and who has symptomatic patients. Otherwise, we cannot do RT-PCR for all patients in the OT, preoperative patients. Okay.
Thank you so much, Choitalidi. We are running very tight on time, and we have so many faculty to come. So we will not take any more questions. Yeah, you are welcome, and thank you, Choitalidi. I can see that Shankho Das, consultant cardiac anesthetist, has asked a question, but we will see, Shankho, if at the end, right at the end, if we can have some time for some more questions. Now, I will invite to the forum Dr. Angshuman Mukhopadhyay. Dr. Angshuman is a senior consultant pulmonologist in MRI Salt Lake. He has already put in quite a few informative comments while listening to us. But before we go to that, let me ask Dr. Mukhopadhyay my first question. Anesthesiologists routinely go for pre-anesthesia checkup of patients posted for surgery. And can you, as a pulmonologist, tell us about certain clinical features in patients, in asymptomatic patients, which might raise a suspicion that this might be a COVID patient?
Well, the first answer to your question, if the patient is asymptomatic, can you hear me?
Yes, absolutely, clear.
The first question, if the patient is asymptomatic, it's a difficult ballgame because you're not going to find any features of classical COVID disease in this patient. So you have to look for mild symptoms. So asymptomatic patients, you will not suspect, nobody will suspect. One is, if you have a universal suspicion, you want to screen everybody, whether they are symptomatics or asymptomatics, then it's a different question. But if the patient is symptomatic, then we'll have to look for the mild symptoms as well. And the mild symptoms means the patient has got myalgia, is not feeling well, feeling uneasy, maybe having a very mild temperature, or maybe having a mild cough. So these are features that should alert the anesthetist to look for a probable mild COVID disease. And then you have to take into account from where the patient is coming from, whether the patient is coming from one of the high endemic zones, or whether the patient has got contact with somebody or is moving around with hospitals with somebody with severe respiratory illnesses, and those are the issues that you will have to look into in those patients. And for patients who are overtly symptomatic, patients with influenza-like symptoms, patients with shortness of, patients with low saturation, then you have separate, you are obviously thinking of a COVID disease in the face of a severe acute respiratory illness.
Thank you so much. Now, there's a sense of unease when it comes to one concern, and the concern is how infectious are the asymptomatic and the pre-symptomatic COVID patients, those who are yet to manifest. Can you kindly answer that question?
I'll tell you one thing. there was a large series from Wuhan which was reported. They reported on 72,000 patients of the initial 72,000 patients, and the demographics of those patients are available. And it is interesting to note that only 1% of those patients were asymptomatic. So if you are looking at asymptomatic patients, obviously their viral load is less and their ability to infect others is really not very clearly known to anybody. So that is my clinical input on that. So you cannot say how much an asymptomatic patient is infected to anybody. You just can't say it at this point of time. We don't have the data.
Okay. That's a nice explanation, and we don't have the science yet to comment on that question. I can understand that. The other question I want to ask you on behalf of the anesthesiologists is that chest X-ray is a very routine examination that is done before every surgery. Are there signs on the chest X-ray which might alert an anesthesiologist that this might be a COVID patient?
In itself, the chest X-ray will be very misleading, but you have to combine the chest X-ray with the patient's clinical presentation. Whether he is having any mild symptoms of acute respiratory illness, that is very important. And to match with that mild symptom of acute respiratory illness, whether there are any X-ray abnormalities. None of the X-ray abnormalities are specific for a COVID disease. You will have either bilateral or unilateral infiltrates, which will be soft infiltrates, peripherally located infiltrates, and that will be all. So when you have that and you have a history of acute respiratory illness, you can either top it up with a CT scan or RT-PCR test, or in whichever form you want to do it. So chest X-ray is very non-specific, but you can say it's the first jumping board for you to trigger the further line of investigations in a patient with acute respiratory illness.
Thank you for a very clear answer to that. And my last question to you would be, and our scientific secretary and the other members who had created this question list, they were thinking that, is there in any way we can understand that a particular patient might decompensate even when the clinical features are not so obvious right now? Are there signs which can tell us that this particular patient will decompensate very soon so that we can take early care?
So our hospital, we are treating a few COVIDs. We have been designated as one of the level 4 hospitals for the government of West Bengal. And like it or not, we have a few of the serious patients coming in. But I would say any patient whose respiratory rate is worsening, any patient whose oxygen saturation is dropping, are the patients in whom you have to look out for signs of worsening. So these are the two clear markers of where a patient's respiratory status is going for a toss. And these patients, you have to sequentially monitor their vital parameters and their oxygen saturations to get a hang of the situation of what's happening.
Thank you. Thank you so much. And you have nicely given clear answers to most of our questions.
I have one small comment about the fact that the bottleneck of diagnostics.
Please.
Yes, I understand. I'll take half a minute on that. It's a RT-PCR test that we want to do. And in our country, the TB diagnostic platform, the GeneXpert platform, is very widely available. And not only the GeneXpert platform, we have another cartridge-based CBNAT test, that is the TrueNat platform, which is also available across the country, almost in any TB diagnostic centers. And if the country gets access to the Cepheid kits, which is the same cartridge-based RT-PCR test, then you can have a turnaround time of only 45 minutes for the test. These test kits have started coming in. MRI hospitals have got the initial lot of 50 to 60 test kits, and we hope to get some more. But with the GeneXpert platform, you can have a very rapid diagnosis of the COVID disease. The sampling would be the same as we are doing now. But then I think the government should be looking at these TrueNat and the CBNAT platforms for broad-basing the tests of COVID disease.
Yes, correct me if I am wrong. The best of my knowledge, the GeneXpert platform is still not approved by ICMR. Am I right?
No, they have validated the test at NIV Pune, and the GeneXpert platform has got a FDA approval. And the NIV Pune has also approved the Gene Expert test. They are in the process of approving the TrueNat test, which is another CVNAT test. So the Gene Expert as of now is approved by the National Institute of Virology.
Thank you so much. We have a lot more faculty coming up, and we have still not made up on our time, because we want our faculty to take some time and explain the questions properly, and we will give them adequate time to take care of that. So I'm not taking an open session once again, and I'm straight away jumping to the intensive care aspect of management of COVID patients. And I have with me Dr. Suresh Ramasubban. Again, this is another person who needs no introduction. Dr. Suresh is one of the senior persons in the critical care faculty of Kolkata. Is a great teacher and a very approachable person. My first question to Dr. Suresh is, can you speak a little about how to provide oxygen therapy in COVID patients, and how do we escalate oxygen therapy when the need comes?
Rahul, thanks. Can you hear me?
Yeah, I can hear you perfectly.
So there's been a problem of whenever you have a patient with, say last night I admitted a 65-year-old lady who came in with a hypoxic respiratory failure, bilateral alveolar infiltrates, and an absolute suspect COVID-19. So the question is, do we intubate her right now, or what kind of oxygen do we give, and what is it? So when she came in, her SATs were 70% on room air. So we slapped face mask oxygen with the instruction not to go beyond 10 liters per minute. So that's the instruction when we give a face mask oxygen, is that any flow more than in HFNC also we are saying that the flow rate preferably should be less than 15 liters per minute. If you're going to go up to 30 liters per minute on HFNC, keep a face mask on top of it and put the HFNC underneath it. So that kind of acts as a preference. So BiPAP is again, if you're going to do a BiPAP, we had doing a BiPAP, we got an 82-year-old man out after 1 month of COVID-19 only on BiPAP because he was DNI. And on the basis of just doing again same thing, you use a critical care ventilator, you use a dual limb ventilator, dual limb for the BiPAP mask, and you have a non-vented BiPAP mask. So these are the three major things that you would do. And preferably BiPAP should be done in a semi negative pressure room or in a negative pressure thing, which we have somehow the luxury of doing it. So BiPAP can be extremely avoidable if you're using, again, the small box BiPAP should not be used. That's for sure. And one of the indicators for both these patients for when you're on HFNO as well as BiPAP is respiratory rate is very important. So if your respiratory rate, even with a BiPAP trial of 1 hour or an HFNO trial of 1 to 2 hours, remains persistently above 35, then you can use something called a ROC index, which is what we are using, which is a saturated SpO2 by FiO2 divided by the respiratory rate, which if it is less than 4.5, it's good. If it's more than 4.5, you tend to intubate an HFNO patient. So that's what we are doing. Just because the mortality of patients who get on the ventilator above 65 age is almost 100% in Calcutta, as far as I know. And in the New York is about 96% for age above 65. And in the whole of Wuhan, it's 82% for patients who get onto ventilator. So we want to avoid ventilation as much as possible because we don't seem to have an idea how to ventilate these guys. So the guidelines, again, we have traditional teaching was if your PF ratio is less than 200, between 150 and 200, you can try BiPAP and HFNC, but less than 150, go ahead and ventilate them early. It's always the recommendation in AIDS. In this situation, we are saying we have lowered our threshold and we are saying that we will do this careful HFNO and BiPAP till the PF ratio falls less than 100 because we are realizing if we intubate them, the result is the same, so might as well. And whoever we have gotten out so far has been on BiPAP rather than on a ventilator. Other than 65, we have gotten them out, but beyond 65, we're not able to get them out. And that is universally true. I think Anshuman will also agree with what they're seeing in AMRI is also about the same thing. Less than 65, we are still fighting. We're just giving them hope. The other thing we are doing is BiPAP prone. So what we call as awake prone we are doing. So that means they're not intubated and ventilated. They're still on a BiPAP. I can upload photographs later on if you want to see the photograph of how we do a BiPAP patient with a critical care ventilator who's on a prone position. So these are the things I would do for oxygenating patient. The key message is that HFNO flow should not go beyond 30 liters per minute. NIV has to be done with a critical care ventilator with a dual lip circuit and with a non-vented mask. And the PF ratio for intubation, we can probably move it to 100 rather than 150.
Thank you so much. That was quite an elaborate explanation of how to take care of the oxygen therapy. My next question to you is a concern to all hospitals at the moment. If we face an explosive outbreak of COVID, how do you plan to take care of your staffing in the ITU?
So what has happened is because somehow MIs have disappeared, somehow heart failures have disappeared, somehow typhoid has disappeared, it's actually easy to manage it right now because we are able to close down our regular, say we are running a 40 bedded ICU, which I was doing, and now it's down to only 20 beds. So what we have done is the 20 bed staff for the is basically now being cycled. They come there, they punch in and they just sit there and do nothing. And we keep them healthy and give them good, keep them ready to go into the cycle. So we have been able to, we have the luxury of space. So where we have a separate dirty building and we have a separate ICU, 8-bedded ICU plus a 14-bedded ward. So we're taking care of 22 COVID patients in our ICU plus HDU plus ward, kind of a single thing together. And we have a separate clean building where we have the regular ICU and the regular building. So we are able to dedicate our staff because our regular ICU footfall has fallen down to significantly low. We are able to circulate our staff between these two units and keep them. So we're doing 7 days on for the doctors and then they're off for 7 days. Then they come back to the regular unit for 7 days. Then they go again 7 days off and they're circulating like that. So my medical officers, my registrars are doing like this.
Right. And if the push comes to shove, I think what has been said in the ISCCM position statement, tiered staffing has to be thought about, in which non-intensivists are supervised by intensivists at some point of time, so that the intensivists can take care of a larger number of patients in the ICU. So, as
we have already taken, most of the pulmonologists have now already graduated to critical care. Is what we have already seen across this thing, is that irrespective of your exposure to intensive care, all pulmonologists by default are now critical care specialists. So that's the tier system which is already done. And simultaneously, we are, I think, getting our internal medicine guys also ready because they seem to have a little bit, because a lot of things are medical patients, because only 5% of our patients are actually sick enough that they require ICU, HDU so far. It's majority ward, so we are actually getting the third line in also.
Thank you. Thank you. And you said that you have a luxury of having a negative pressure ICU in a pool. Yes. But for other hospitals which don't have it, what do you think would be the second best alternative for?
No, I don't think it's necessary at all to create this thing. The one other thing is that if you're not doing any aerosol generating procedures, which is nebulization, BiPAP, intubation, extubation, bronchoscopies, upper airway endoscopies, so for in the ICU, it's basically intubation, extubation, and BiPAP. So if you're going to do all these things and nebulization, if you're going to do these things, ideally it's an aerosol generating procedure. So one of the recommendation, if you have the ability, which Dr. Yogiraj said, if you have a split air conditioner, when you're doing an intubation, you can stop the AC and leave the window open. So that's something for 15 minutes you can do. Then you can do, after 15 minutes when the aerosols have settled down, you can restart it. That's something which is very easily doable if you have a single window AC in a room like that, which again in a central air conditioned of most of the private corporate hospital is not possible. So there in that situation, you will have to undergo that. You have to have a box, or you will have to have some other way in which you minimize aerosolization when you're doing a procedure which requires aerosolization. Like for instance, I told you with the HFNO, we are putting the HFNO nasal cannula and then putting a face mask on top with nothing running on it to act like a reservoir and to prevent aerosolization. So these kind of things, only thing can be done everywhere. In the US where I work, I have a 22-bed ICU with only 2 beds for negative pressure. And right now all 22 patients are in COVID positive on a ventilator in Chicago. So the purpose of, you cannot plan for a negative pressure room for 22 patients anywhere in the world. So let's forget about it.
Thank you. Thank you, Dr. Suresh, and wonderfully explained all my questions. We have here amongst us the Secretary of National IACTA, Dr. Rajesh Arya. Welcome, Rajesh. If you can unmute yourself. Dr. Rajesh has a recommendation and a comment to make on negative pressure ventilation. Rajesh, please.
Yeah, good afternoon, everyone. Good evening, everyone. I sent a video about how, we take so much of precautions of patients about 3 minutes of intubation, like how to reduce the viral load or aerosol load for the 3 minutes of when we intubate. But once the patient is intubated, what the exhaled gases or expired gases are coming in the ICU, and most of the ICUs are the closed chambers, most of the places with the central AC. So all this aerosol, they remain from the expiratory port of the ventilator, like it comes from the patient to the circuit to the ventilator and comes out. So I prepared a video and I sent to many people, and finally I got a reply that we are using filters. But most of the places that people are using HME filter, which does not give you protection against the viral load. So the answer was, okay, we are using viral filters. Still, may I ask a simple question to everyone? If you are putting a filter between the patient and the eyepiece, that's the most common place where you put the filter, fine. So if you put a filter between the patient endotracheal tube and the eyepiece, and you presume that the virus are trapped there and they don't come outside from the ventilator to the atmosphere of the ICU. But when the sister is going to do the suction of the patient, when you do the suction, you disconnect the filter from the endotracheal tube, but the ventilator is still on. And the ventilator is still on and it is giving the positive breath to the air. So all these viruses which are trapped in that filter, they again come to the atmosphere. So is it the right thing we are doing?
No, you should not be suctioning them without a closed circuit suction. You should not be opening it to do a suction. Open suction is not allowed.
But in a country like us, the closed suction is practically not feasible, and especially when you have got 10-12 patients of COVID in the ICU, and the government set up mostly, it's not possible to have a closed section for all patients in ICU. That's a practical problem with the countries like us.
Agreed. There are a few views and there are a few opinions in this thing. I think we will come back to this very interesting discussion which you have raised. But for the sake of time, let us just get back on track. And I have with me.
May I suggest an answer to that? May I suggest an answer to that? A solution to that?
Please answer to that.
Yeah. So what we suggested, don't put the filter between the endotracheal tube and the circuit. You put two filters, one on the inspiratory limb and one on the expiratory limb of the ventilator. So, I mean to say that close to the ventilator, not to the close to the endotracheal tube, away from the endotracheal tube and close to the ventilator on the inspiratory and the expiratory limb, so that whenever the circuit is disconnected, the viral load does not go to the atmosphere. And on the other hand, on the expiratory part of the ventilator, you put some negative suction, as I displayed in my video, that you put a negative, you trap the gases in a chamber and then you put a negative suction so that the expired gases from the ventilator go to that chamber and they're sucked out. Same way on the patient and just connect the tube with the circuit, and the filter should be applied on the expiratory part of the ventilator, close to the ventilator, so that the inspiratory gases don't push the viral load back to the atmosphere.
Thank you. Thank you, Rajesh, for your opinion and insights. Let me invite Dr. Shubhro Roy Choudhury. Shubhro, all of our senior, is a very reputed interventional radiologist working at Artix and at other places. Shubhro, my first question to you is, how good is HRCT in detecting COVID? Can it reliably rule out coronavirus infection? You need to unmute yourself, Shubhro. Ashok, can you unmute Dr. Shubhro?
Got it, I've got it.
Yeah,
so,
fine.
Yeah, can I share my?
Yeah, absolutely.
Okay, so the question that you asked me, one second. Can you see it, guys? My screen? No.
Yeah, now we can see.
Okay, so the question that you asked me is, how good is HRCT in diagnosing rather than in prognosticating COVID? We're not going to talk about prognosticating COVID in the middle of the illness. We're only going to talk about diagnosis. So the simple answer to your question is, it depends upon the population that is being tested. So if you're going to test the the general population at risk, as in the community, then the chances of finding COVID or diagnosing COVID is very, very small. The sensitivity is poor, and we do not have any data at a community level of testing. But if you are considering doing HRCT or CT in a symptomatic population group, as in a patient presenting to you with SARI, or in a patient with a positive epidemiology in terms of contact or hotspot, etc., so the typical way that we have used it in our hospital setting, then the accuracy of HRCT is quite high. We'll talk about that, the numbers, in a second. The second important factor that it depends on is the timing of the HRCT. Obviously, the sensitivity of HRCT is poorer in the earlier part of the illness, but from the start of onset of symptoms, the sensitivity of HRCT is pretty high. You're talking about 75, 80, 85%. I'll show you some papers in a second. So the bottom line is, it depends upon two things: your population you're testing. If they're symptomatic with fever, with SARI, then the sensitivity is high. And the second point is that at what point in time of the disease are you testing? And the third important point is that what criteria are you going to use? So I'm just going to give you this little thing. I don't know whether you can see my screen. So if you just look at this, this screen, if you look at the way HRCT, if you want to standardize this report, the way HRCT should be reported by us is based on all these criteria that we know, peripheral, ground glass, crazy paving, consolidation, low predominance, parahylous sparing, absence of tree in bud, absence of nodules, absence of pleural effusion. So you've got a set of positive findings, you've got a set of negative findings. So based on this, if you are going to call only your typical appearances as positive, then your sensitivity is lower. But what we do when we are using HRCT as a screening tool, we are going to call both the typical and the indeterminate group, so the top two groups, as likely to be positive. Thereby, you're going to increase your sensitivity, but you're going to drop your specificity. So the typical CT findings. By this time, everybody has gone through this. Peripheral, ground glass, crazy paving. I've mentioned all of these. A prominent vessel in the middle of crazy paving, traction bronchiectasis, etc. But let me just talk to you about this. So, for example, if you're very early in the illness, as you can see on the very left side, the imaging findings are subtle and non-specific. But as you go a little bit more into the illness, the imaging findings become more definitive and diagnostic. And of course, you have the middle picture on the top row is the negative atoll sign, which is regarded to be a specific sign for COVID-19. You have to remember that the literature and the evidence is changing daily. Even that is not a specific finding. But I just wanted to show you this one little case that we did the other day. So excuse me for the other noise that is coming through. So if you look at this one, okay, you've got patchy ground glass in both in the upper lobes, in the apical segment, as well as in a peripheral distribution in the lower lobes. There is peripheral, there is perihylous sparing, there is no frank consolidation, and the negative features are not there, but there is upper lobar involvement. So if you are going to go and call this according to the strict definition of COVID CT, this is not very usual because of the involvement of the upper lobe. But in my practice, I'm going to call this a COVID positive, accepting the fact that I'm going to lose on the specificity because I've called an upper lobe abnormality as positive. So I'm going to include this, which otherwise would have been an indeterminate group, in our setting in April in India, where the pretest probability of influenza due to other causes is less. I'm going to call this positive. If you are going to tell me that this patient has got SARI, if you're going to tell me this patient has come from a hotspot, if your pretest probability is high, I'm going to call this positive. So and to answer your question, it depends. I mean, to be honest with you, the meta-analysis says a pooled sensitivity is 94%. I mean, that is very high, but the pooled specificity is 37%. So it depends upon what threshold you have. If you are happy to be called yourself false, you have called yourself false positive, so then you can keep your false negative rate very low. So if you're using it as a screening tool, this is the attitude you should take. So you should improve your sensitivity at the cost of your specificity. And this is very rapidly done, but this is an AI, somebody mentioned this, AI augmentation, or I think Ongshuwanda mentioned this, AI augmentation of radiologist performance. Just look at this bottom line. I've circled these for you. the average accuracy is 90% for AI versus 85% for radiology. Specificity, sensitivity, all in the 90s. So if you are actually in the right clinical context, in the right time of the disease illness, and you've got a radiologist who is happy to take the clinical features on board, you can have a very high sensitivity. And Rahul, you know that even in our hospital practice, that's the experience that we got.
Yes. And we are indeed doing a study where we are correlating HRCT with our RT-PCR findings. And hopefully, Shubhrata, that will throw some light on how this compares with PCR. Yeah. But thank you so much, because you gave a very detailed explanation of how it can effectively rule out false negatives. I come to the second question, is that CT is logistics intensive. The patient has to be taken to the CT suite, there are technicians there. How do we take care of the sterility and not getting the technicians infected? How should the workflow be?
So firstly, I mean, institutes that have only got one CT, it is a problem, because there are standard guidelines issued by all radiology organizations. I won't go through all of them, but suffice it to say that if you have a suspect COVID patient being scanned, then you need to do the surface cleaning as per the standard norms, and need to air clean it for a time of an hour. So that would interfere with your normal CT workflow in any hospital. So hospitals like Apollo or ourselves who have got a second or third CT scanner, then you can dedicate a CT scanner towards a COVID scanner. That is useful. But generally speaking, the other point I wanted to make out, avoiding the use of CT to some extent, is two things. One is how to, firstly is accurate history taking epidemiology study. You need to have a clear communication to the CT department that a patient with a query COVID is coming. It should not come as a surprise that, oh yes, that patient was a surprise. So then you've got a whole team of people who are not prepared, who are not adequately PPE'd, who have been exposed. But the other thing that is very relevant to your group of, your specialty is the use of chest X-ray. So we need to use chest X-ray in a practical way, often which is with a dedicated X-ray machine, which is often portable. And of course, the use of point of care ultrasound. I mean, these two modalities, please don't forget. X-rays, I'll tell you one thing, we are just doing a study on X-rays only. X-rays are sensitive in 69% cases. It is not high, but remember, a primary PCR one test result for the time being in the initial part of our pandemic is about 75% anyway. So it is not that far off. The X-ray findings can be very subtle, but if in the right clinical context, a chest X-ray, which can be stationed in your COVID unit, can be very, very good. For example, the bottom left picture that you can see on the X-ray, yes, the ground glass changes are very subtle. On the right-hand side, the pictures are obvious. But that subtle finding, if you are clinically suspicious, if you have got a good pair of eyes or an expert pair of eyes looking at the X-ray, then X-ray can be used in a very successful algorithm within the hospital. And of course, there is a scoring system. I won't go into that. But the other thing that is probably one or two of your correspondents mentioned in the questions I saw is about point of care ultrasound. I mean, the Italians have used point of care ultrasound as both as a diagnostic and prognostic tool. Wonderful. Some of the papers that have come out is wonderful. You guys have got more experience on A lines and B lines than we have as radiologists. But to be honest with you, this to me, the main role of point of care ultrasound is actually prognosticating a COVID patient, following up a COVID patient by understanding that this area of consolidation, by giving the steroids, has it improved or not? By giving the antiviral, has it improved or not? So your quick on-the-spot decision-making, your treatment plans that are changing every day, point of care ultrasound can help you rather than asking you to go and get CTs every time. So you can reduce the burden on the CT by using this, but once you're going to use the CT, you need to have a clear lines of communication with the technical team that a patient is coming, please be prepared. If you are got a dedicated scanner, great. If you don't have a dedicated scanner, you need a 1 hour air time to clean it.
Thank you, Shubhrata. That was very comprehensive and answers all of our questions which we had for you. If we have time right at the end, we might have a few other questions. I want to jump to the next faculty and go to the next topic for discussion. Shubhrata, if you please. Yes. Our next participant and our next eminent faculty is Dr. Shoykot Sengupta. Shoykot Da is all of our senior. He's a very well-known academician. And Shoykot Da will be talking about the PAC, the pre-anesthesia checkup of patients in COVID. Shoykot Da, my first question to you is, you can test preoperatively by a PCR. You can, as Shubhroda nicely explained, do HRCT, or you can do a PCR plus HRCT. Which one does make you most safe and comfortable? I think you are unmuted, Shoykot Da. You have to unmute yourself. We can't hear. Yeah, perfect.
Thank you, Rahul. Good evening. Can you hear me?
Absolutely.
All right.
Perfect.
And I think, batchmates always are very, very similar. So I think I just take a cue from Shubhro, and we have spent years together and we have been roommates together in medical school. So I also will share my screen with all of you guys, if you don't mind. So can you see the screen?
Yes, we can.
Okay. So I think the flow would be about preoperative screening. And why are you talking about preoperative screening today? Most often you do assessment is basically to figure out what is the burden of the disease that you are treating for the surgical pathology, isn't it? And you are also trying to figure out whether you can optimize. Now things, because of this COVID, has changed. Actually, the perspectives have changed. Till 2019, January or February, we used to be very patient-centric. We used to call that we're looking after patient quality, patient safety. And come at this bug, we not only talk about patient-centric quality and safety, we talk about our own quality and safety. And this is where we are really bothered about preoperative screening, because we are, honestly, put your hand on your chest and you figure out, we are honestly bothered, is that patient very likely to give you the bug, to give your colleagues around you the bug, maybe the surgeon, maybe the intensivist, maybe the healthcare worker, the nurses, technicians, everyone involved in that facility, which is why this preoperative screening bit is becoming a big bugbear for people coming in for surgery. And I think Anshumanda talked about this asymptomatic 1%. The rest of them, other than the people who are coming into the hospital, you see the symptoms are very vague. The clinical features are pretty vague, isn't it? Like fever, fatigue, dry cough is possibly one of that. Myalgia, anybody with a little bit of viral kind of an illness will have this. And forget about this 1% asymptomatic. What really bothers many are these people who are in the prodrome period, that is, they're carrying the bug, or they're in the incubation period, they're shedding the virus, and they have the capability to infect. And this is the one that possibly is the most difficult to pick up. And this is where preoperative screening, as you were mentioning, would come in. So what would be you would have your kind of suspicion level very high, you would have your normal tests that you order, and you try to figure out in those normal tests, is there something that I can pick up which is making me more suspicious? Lymphopenia, elevated amylase levels, elevated LDH. If you have ordered for CRP, ESR, are these levels high? These are kind of things that can raise your levels of suspicion. Shubhro already mentioned about this. I'll not go into details. And even vague things in ECG, which I would have passed by, if you find that, and you find that they can present with early myocarditis, this is a level of suspicion, I think, which you need to have more. And then you look at the specific tests for COVID-19. So with the specific tests, I think it's no gamer. The WHO tells you that the specific test is the nucleic acid amplification test, like the RT-PCR. Now, the problem with the RT-PCR, and everybody knows about this, that you have this high false negative. So you'll do an RT-PCR, it might come negative, but 30% of them would be still carriers, and they will still be able to infect you. And the reasons are many, which are elicited. So the next question, I think, which comes into the mind is, yes, the RT-PCR is once negative. Should I repeat it? And how confident would I then become that if the RT-PCR then is negative, that is actually not COVID-19. And I'll just put you 2 points that have come through evidence. Look at what does it say? 2 negative RT-PCR tests within 24 hours. Absence of clinical symptoms is still not stringent enough. We are really dealing with a very notorious and a bad bug. We still haven't got over the bug, and we don't know what it's an early. You can call it that it's a very it's an early disease. It's just 3 or 4 months. We still don't know enough. This is so. How many times will you do RT-PCRs? And an RT-PCR may still remain positive, but the patient may not be infective because he's not shedding enough virus in patients who have clinically improved. So actually, if you're looking at pre-operative, I'm not trying to confuse, but if you're trying to look at evidence, what is evidence telling you? I think we still don't have a very clear-cut evidence. So you can do it 24 hours after 48 hours separated and still not be sure as to what you are dealing with. Now coming to, other than RT-PCR, do you have other modalities of testing, as you were asking? I think Shubhro elaborately went through how when HRCT becomes important. And you see, in today's day and age, the evidence that we'll be having, most of it will be preprint. And if you look at this Center for Evidence-Based Medicine from Oxford, which gives you a lot of these preprint things, and if you look at what they have been telling you, that we still don't have a verdict. You can look at multiple screening criteria, clinical features, the RT-PCR from multiple sites, multiple specimens, yet not very corroborative. The HRCT at different points in the disease with an RT-PCR positive, with an RT-PCR negative. I think most of them are from Wuhan. You would have an RT-PCR positive, or rather an RT-PCR negative, but an HRCT very confirmatory in quite a significant number of patients, which can lead you to a scenario where the false negatives will be then reduced in single digits. You can incorporate things like white cell counts reduce, lymphopenia along with it, the serum antibody testing, the combined ones, IgG, IgM initially, the 7-14-21 IgG, combine it together. Even then, or have the biomarkers like CRP, procalcitonin, ferritonin, IL-6. None of them, unfortunately, will still give you a complete 100% proof. And that's what I feel, and I think most of the world feels. You still do not have a gold standard test. And we still do not have a gold standard combination of tests. So I think if you're trying to ask me about testing, that is what I would think about testing.
Thank you, Kolkata. I mean, it was fantastic. You have taken us through right from the clinics to all the available tests and going on to show that whatever be the test result, a full personal protection is mandatory. Absolutely. When you give and take care of COVID patients. Thank you so much. My second question to you is what is doing rounds now in various circles is informed consent for COVID patients. Now, as an anesthesiologist, when you are taking informed consent for a COVID patient, do you want to tell something extra, something different to these patients?
Rahul, if I can just have a couple of minutes and take you through, I think that was interesting as you take you through what we have been doing before we take up a patient and before we consent, the kind of flow. And I'm fortunate to be working with Suresh for such a long time. And Suresh, myself, Shamash Isda, we sat together and we have kind of formulated a way as to figure out what to do with these people who would possibly need time-sensitive surgeries. And what we have done for the last maybe 10 to 15 days is not have low acuity surgeries. Intermediate acuity surgeries also try and postpone. It's the high acuity surgeries that we have decided that we need to go on and do it. You can't kind of deny them. So this is what we have. And I think Suresh took us through this kind of system that we have in the hospital. People who are familiar with Apollo would know this. So essentially, if you look at emergency, it's easier. You have to operate, right? And what we kind of do, they come directly from the ER to the OR. So if the surgical pathology tells you this person needs to go to the CT scanner, what we say is, please do an HRCT as well. So we kind of cannot pick up a bit. So they proceed to the emergency operating room, which is still in the main building, right? But fortunately, this operating room has a separate air handling unit. So this will not kind of contaminate the other areas. We assume that this person could be COVID positive, or at least a COVID suspect. So full PPEs for everybody who's going into the OR. And from the OR, the person goes to a negative isolation room or negative pressure isolation intensive care. And then the swab is taken from them in the post-operative, and then we decide where the person goes based upon the result of the swab, whether to come to the clean or building or to we call it the dirty building. Okay. For time-sensitive surgeries, this is what we have evolved. It's like the patient and the relatives come in together in the morning, and the corporate hospital, they need to pay the bills, right? So the attendant goes to pay the bills. The patient, along with the hospital representative, goes to this what we call the standard screening and surgical ward in the so-called dirty building, 5th floor, wherein the swabs are taken, and they stay there till evening, kind of, till we know the report of the swabs. And if the swabs are negative, they're shifted back to the main building, to the clean building for the surgeries. And if they're positive, then we really take a call. So far, we have had one such. We had to postpone surgery, and appropriate care was done. You can face a scenario of logistics wherein you may not be able to do RT-PCR. The classic example is, say, a trauma with something like, may not be for cardiothoracic surgery, but you can have a vascular injury, for example, and you do not have time to maybe do this, but you have 6 hours to stabilize or kind of something like this. We have developed this kind of scoring system, and which is essentially clinical features. Contact, what we also have is this resident of a hotspot. And if one of them is positive, you score 1. Or you do an HRCT thorax. And as Shubhro was mentioning, I think we also kind of, it's just not GGO, patchy shadings, atypical imagings, anything is taken as a positive score. If either of this you don't score, so it's 0, then you're kind of reasonably sure that it is. And I think Suresh has already kind of worked on this data, and we have, along with it, when you have put in CRP and CBC, we have seen that when you're correlating with a RT-PCR, it is coming to around 96 to 97%. Suresh, this is data that I'm already leaking that you are supposed to be sending.
I think it's a 100% negative predictive value if you use lymphopenia, and HRCT and this thing, procalcitonin together.
Procal, I think, which is see on the right side of the episode. So essentially, that is the kind of thing that we have discussed, figured out. The rest is prayers and PPE. So even after all this, you will have to assume that they could be. Now, coming to consent, I think it has to be very open. I was trying to search after you asked me and Shomi asked me, so what extra would you do about consenting? And I was trying to look at what other people are doing it. The Royal College of Surgeons UK have still not developed anything specific to go with this. They are going with the same consent. SAGES are saying that you possibly can quote this, that they have a higher risk of picking up infection, but the risk is around 0.45%. So since it is greater than 0.1, so they said it might be mentioned in the consent. The Dental Association says nothing doing but it's just the same ordinary consent. The Indian Journal of Ophthalmology, I think this is the only Indian association which has definitely come out with a statement saying that, yes, you need to mention and consent them accordingly. I was looking at the position statement of ISA, Indian Society of Anesthesiologists. There's nothing specific to the consent as yet. And the plastic surgeons, many people would say they are the most meticulous people. So they have got now, the American College of Plastic Surgeons have a specific consent where they mention everything about COVID that they can pick up, while they're in the hospital. So for consenting, I would say that you have to develop your own thing. We are in the process. We still don't know whether you put in a number to the risk that is added, or you say that, yes, in this current pandemic scenario, this is a possibility.
Thank you. Yeah, so basically, looking at the documentation that's moving around in the web and some of the hospitals in southern India who are taking care of informed consent, as you said, Shoikota, basically two things. There is risk of contracting the infection while you are in the hospital in the middle of a COVID pandemic. And the other thing is that they have to follow the rules and the regulations in the hospital when they're there. To avoid spreading or contracting infection. So something order has to be devised and every hospital has to have an informed consent of their own.
I think, Rahul, I would completely agree with you. I think more than the consenting, I think it is communication. I think there should be a completely different communication form that should go to each and every patient who is coming into a hospital, irrespective of surgery. So if any patient, and that is about everything, about physical distancing, how many times a relative can come in, what they are expected to do in the hospital, what their relatives are expected to do at home, and how they can possibly help in not making the hospital a hotspot. And also about, you can also figure out there is this huge apprehension in the public about coming into a hospital, despite the fact that they need to come into a hospital because of picking up the bug. I think that the communication part should also take care of the fact, make them confident that yes, we are taking precautions, the healthcare workers are being checked, and that you have a reasonably good chance of not picking up the bug when you're in the hospital as well.
Cannot agree.
One of the things I communicate with when I round in the COVID ICU and COVID ward is I request all the patients to close the lid of the toilet before they flush it, because that's an aerosolization procedure. And that's, I think, we should practice at home also.
Right.
Yeah, and thank you so much, Shoikota, for giving us an excellent background on the entire pre-anesthesia checkup of patients. I would love to now invite Dr. Pradeep Narayan. Dr. Pradeep is a consultant cardiac surgeon at Ravindranath Tagore International Institute of Cardiac Sciences. He's also the associate editor of the Indian Journal of Cardiothoracic Surgery. Pradeep Da is a very well-reputed academician, and welcome, Pradeep Da.
Thank you, Rahul.
My first question to you is, anesthesiologists and surgeons and doctors and healthcare professionals working in COVID areas, high-risk areas like operation theaters and intensive care unit, could you take us through the essential PPE that they need to wear in COVID areas?
Yeah, sure, Rahul. Before I do that, I just want to say two things. First of all, I read in the papers today that most of the newer COVID patients are actually healthcare professionals. So everybody who's listening to this talk, everybody in this meeting is actually a potential COVID patient. Second thing I want to say is PPEs are overrated. Okay, it's not the PPE that protects you. It is the PPEs are only as good as the person who is wearing it. So PPEs, actually it is your attitude towards the whole thing that protects you or predisposes you to COVID. Now, coming to the question you asked, see, we all are coming from different backgrounds. Some of us have got body suits available. Some of us are even struggling to get a face mask. So we have to take that into account as well when we decide that what PPEs we should be wearing. But if you go to the WHO or the CDC website, they have got a very extensive, breakdown of the different clinical scenarios, what situation you are in and what you should be wearing. It is all quite complicated. But actually, if you ask yourself just two very simple questions, you'll get all the answers right. And the first question is, who is this patient you are dealing with? And the second question is, what are you going to do to this patient? Now, the first question, who is this patient we are dealing with? Now, even in this meeting today, we talked about asymptomatic patients, symptomatic patients, atypical presentations, typical presentations, people coming from red zone and not red zone. I think we can just safely forget all of those. And just remember, there are only two categories of patients who come to the hospital and will be coming to the hospital. One, people who are COVID positive. Two, people who are suspected to be COVID positive. There is no third category. So every patient that we look at is a potential COVID patient. Now, the second question is easier to answer, that, what procedure are you going to do? I mean, you people know it better than me. If it is an aerosol generating procedure, your precaution should be the highest possible, level 3 as we call it, and it should be the highest possible PPE that your facility allows you. So, for instance, in our hospital, it will be body suits. In some other hospital, it could be a gown, N95 mask, gloves, and eye protection. So we have to just juggle around with those. At the very basic level, I don't think any of us should see any patient without a mask and gloves. And that mask should ideally be an N95 mask or a respirator, or at least a surgical mask. Cloth masks, contrary to what we have been told, are useless for healthcare professionals. They are good enough for patients, they are good enough for normal people, they're not good enough for us. And this is a data that is there on CDC. CDC has clearly said that they are useless. So if you are using a cloth mask, you might as well not bother, just go and see the patient without a mask.
Thank you, Pradipda, for bringing some perspective into this entire question. You nicely said that whatever is the best available PPE in that hospital should be taken by the healthcare workers. And that is a nice take on this entire question. My second question to you on behalf of the society is that anesthesiologists also, other than visiting operation theaters, go to the wards for the pre-anesthesia checkup of patients, and all of them should be considered as COVID suspect. When we are talking of PPE, is this a different PPE that they should wear when they are doing a pre-anesthesia check in a ward?
No, Rahul, I think it's pretty much those four things. If you are suspecting it's a COVID patient, as you should be, or if it is a COVID positive patient, you should take full precautions. See, we all know it, and it has happened recently in our hospital, it has happened in other hospitals as well, that you have gone and seen a patient who was absolutely normal and asymptomatic, and 2 days later he turns out to be COVID positive. And then you're surprised that why did you put the neckline or why did you put the Venflon with your bare hands? So that attitude has to change. That is what I'm saying, that the attitudes have to change. We have to treat everybody as COVID positive, even if the COVID test is negative, because as we know, it is not very specific. So the first test is negative, please don't think they're COVID negative. You have to treat them as COVID positive. So, again, mask and gloves, that's a minimum you should be wearing if you're going in a low risk area. Obviously, we have that sense, that this is a low risk zone and it's unlikely, but at least if you're wearing a mask and gloves, that will protect you to a large extent. I'm not saying that you should be wearing, full PPE and go there.
Thank you. Thank you so much. Coming to the issue which United States and the UK are already facing, and we might face anytime soon, is an explosive outbreak. And in that situation, PPEs have to be reused. And what is your recommendation on reusing of PPEs?
Yeah, see, again, this situation is unique. The world has never seen anything like this. So whatever is based on very little evidence. There has been some experience with earlier viruses, and the recommendation is that the respirators or the N95 masks, they can be reused. Now, how often can you reuse them? The CDC recommends 5 times. And so what they suggest is, and they have also said that it takes 72 hours for the virus to die on most surfaces. So they have recommended that everybody should be provided with 5 masks, which they can cycle after 5 days. Now that you can do it at home. I don't know if facilities exist, but the best way to sterilize this or disinfect these masks is using your ultraviolet radiation. You can also use moist heat, which is used to sterilize infant feeding bottles, but I don't know if you do it. And third one is vaporized hydrogen peroxide. One thing which we all do in our hospitals, in all hospitals, is ETO. Now, I would strongly recommend against using masks which have been ETO'd, because that ethylene oxide is carcinogenic, teratogenic, and neurotoxic. So if you're wearing a mask that has been ETO'd for 2 or 3 months or 6 months or a year, we were exposing ourselves to all these problems. So yes, it can be reused. the masks can be aerated for 5 days and then reused. So, with 5 masks, it will go up to 25 days. I don't think most facilities do not have these facilities to, disinfect them. But when you are reusing them, you have to be careful that, they are intact. When you are taking them off, never ever touch the inside of the mask. It always has to be the outside. You can clean them from the outside, but then you have to use something like sodium hypochlorite to clean it. Don't use substances that will penetrate inside. So yes, and we can reuse it, but only to a certain extent.
Thank you. Pradipta, as I know personally, you have been going around teaching our healthcare providers on the right way of donning and doffing PPE, and we have been taking classes for the residents who are going to the COVID wards for duty. My question to you is, based on this, what are the challenges that you see when people are learning to wear PPE? Where can they go wrong in using the right PPE?
Actually, Rahul, I think that's probably the most important question that you have asked me. I think that's the biggest disaster. PPEs are actually the biggest disaster, because when you wear PPEs, you feel that you are safe. Actually, you are most unsafe when you are wearing PPE. And I can tell you, I know of a hospital where there was a single COVID patient who was looked after by 4 healthcare professionals in bodysuits. All 4 of them became COVID positive. And where we go wrong is not wearing. What the mistake we make is we try to be very careful when we are wearing them. Actually, it doesn't matter. You wear the PPE in any order you want, you roll on the floor and then go to the patient, it makes no difference. What makes the difference is when you take them off. You have to be very careful when you are taking them off. You have to take the gown off, you have to, the gloves off and the gown off. Now, there is some, CDC has already changed the way they say that you can doff twice on their website. But basically, they accept that any method is good as long as you follow it properly. The one I personally like is you first take your gloves off, you then take your gown off, and then you walk out of that room with your eye protection and your face mask on. This is the commonest mistake which people do. They take off everything inside the room and walk out. That is as good as me entering without any PPE inside the room and staying there for 5 minutes. So 2 things, gloves and gowns have to be taken out inside very carefully. While you take off the gloves, because unless you are a surgeon and you're used to taking them off every day, it is quite easy to contaminate yourself. What you should do is you should try and wash your hands in between or sterilize them as you go along. But the other 2 things, the respirator and the eye protection, has to be taken out after you have come out of the room. And again, at the end of all, you should wash your hands.
So you mean that the respirator and the eye cover has to be doffed in a separate area?
Correct. So you come out of the COVID area where you've seen a COVID patient, and just outside that, there should be an area where you can get rid of those 2 things.
Thank you so much. Thank you so much, Pradipta, for taking us through the proper PPE usage. We are still a little behind on time, so I think we'll keep all the questions right at the end. Our next session is on the use of transesophageal echocardiography in times of COVID. And we have our very dear colleague, Dr. Shoikat Bandyopadhyay. He is a senior consultant cardiac anesthesiologist in Fortis Hospital. And Shoikat, my first question to you is, how do we avoid overdoing PE in pandemic, and how do we optimally use this mode of imaging?
Hi, good afternoon, everyone. Is it possible that I can share my screen?
Please go ahead, Shoikat.
Can you see it?
Not.
Or am I audible?
You are audible, but we can't see the presentation.
Okay, I think the question is how to optimally use tea and how not to overuse tea in times of this pandemic. As Dr. Pradeep Narayan just before me pinpointed that, whether the patient is, RT-PCR positive or negative, either way, all patients can be potentially COVID positive. So the first question, there's some questions before I do a TE, I need to ask myself. So do we really need to do the TE? What are the real indications for which, I would probably go ahead and do the TE in a probable COVID patient? And do I have any alternative methods? Possible alternative method would be only transthoracic echo, and other options could be, CT or MRI, which can help identify supposedly, a clot, a thrombus in somewhere in the heart, LA appendage, intrahiatal septum, LV apex, somewhere. And if I actually go ahead doing a bedside TE, what are the risks that I might face? Now, if I answer these questions, probably, I can come to that point with your question, whether and how I can avoid overusing TE. Now, one of the main indications of doing a TE is, patient is unstable. I would like to know whether the patient, this instability is because of, a direct effect of the virus or cytokines causing stress cardiomyopathy. For example, Takotsubo cardiomyopathy, in which you will see apical and mid-level akinesia with basal hyperkinesis. And my point is, if there might be a poor window, because the patient is ventilated, or patient is heavy-chested or otherwise. Now the question is, if you can go ahead and do a transthoracic, which is much less invasive than a TE, I would probably choose TT, in spite of the fact that the picture might not be very good. But if I can actually identify, wall motion abnormalities, then I'll probably go ahead just to TT rather than a TE. Now the question of COVID being a prothrombotic state, pulmonary embolus, intracardiac thrombus, and exacerbation of coronary artery disease, all are potential things that I need to rule out. And probably TT is not good enough. In those cases where you are expecting, a thrombotic episode, a source of intracardiac embolus, the other option could be a CT angio or a MRI looking into the heart. So again, the question then arises, shall I shift the patient from a COVID bed to all through the transport, through the lift, and eventually to the CT or MRI suite, and increase the risks of, hospital transmission? So weighing the pros and cons, probably one of the reasons why I would probably go ahead doing a TE is to identify pulmonary embolus at the bedside or other source of intracardiac thrombus. So I think that answers your question.
Absolutely. And in the way you also discussed about the other modalities which can be used for transesophageal echocardiography. So the question to you is, if we are forced to do TE, what are the precautions that we should take?
I think the biggest risk for doing a TE, especially if your patient is not intubated, on an OPD basis, patient is, awake alert and with a high respiratory rate, you're taking a huge risk because whatever you use, a light sedation with a little bit of fentanyl can cause fentanyl cough, or suppose you use the spray, which you have to. So the xylocan spray is irritant, it is bitter, and it definitely induces cough. And while you're introducing, and all through the procedure, the patient might, bark and cough over the TE. Every time there's a chance of generation of, a lot of aerosols releasing, if the patient is positive, a lot of virus into the environment. As we all know that aerosols last in the air around 15 to 20 minutes at least, depending on what capacity your AHUs, they have in handling the cycles per hour, at what rate they are set. But overall, at least 15 to 20 minutes, the virus would remain in air. So if you're not taking precautions like a full PPE, your N95 or N99, FFP3 kind of masks, and your eye shield, the full PPE protection. Not only yourself, but also the technician who is beside you, the nurse who is inside the same room. You are increasing the risks to everybody. So, you need to basically have the minimal amount of people inside that room. That room should preferably be a negative pressure room. And I think these are the precautions that you should always think of while proceeding with a, OPDT. In case of TE, if you are sort of going at in a patient in the ICU where the patient is already intubated, the risks of sort of aerosol generation is much less. But even then, whenever you're doing a semi-invasive procedure like a TE, you have a very high risk of getting the virus to yourself and people around you. So a PPE and full precautions that we discussed all through till now, we have to use those precautions.
Absolutely, Shoykot. We have Dr. Vinayak Desurkar, a very senior member of with us in this forum, and he's saying the same thing that OPD-based TE, very importantly, people doing it has to wear the full PPE and maximum.
Right. Absolutely.
Now, going to my next question, which is of very important relevance to cardiac anesthesiologists practicing in the ORs. After you have done a transesophageal echocardiography, how do you disinfect at the machine?
I think the first is disinfection of the machine, and the biggest question is the probe which has gone inside the patient. How do you disinfect that? So I think the big difference in this case is that the person cleaning that probe should be wearing a full PPE, and the first cleaning using whatever, a detergent-based or a chlorhexidine and alcohol-based wipe should be done in the same room where the TE procedure is done. This is to reduce the load of the virus, which is, with the saliva and which is on the probe. So once you do that, you reduce the load of the virus, then the person with full PPE takes that probe to a designated area, which is not a routine area where you clean other things. It's probably a designated area where you have a tap and you use soap water to cleanse that probe. And in that particular area, you should hang it to air dry it. And after the probe has been dried adequately, you have to soak that in a high-level disinfectant, depending on the hospital protocol that you work in. It could be Cytex, OPA, some sort of a hydrogen peroxide containing liquid, which is recommended by the hospital authorities for 15 to 20 minutes. And once that is done, you take it out, again wash it with water, dry it, and store it in a closed box. And regarding disinfection and cleansing of the echo machine, I think every time you do that, as I say, the aerosol can be generated. You should actually cover the entire machine with a plastic, transparent plastics, so that whenever you're touching, sort of adjusting different buttons on the interface, the echo interface on the machine, you have a very high chance of sort of infecting those buttons. So I think the best way to prevent that is to use a transparent plastic so that you don't directly touch those buttons or knobs. And once it is done, you can throw away the plastic and the transparent sheet that you are using to protect it.
Thank you. Thank you, Shoykot. And that was pretty comprehensive. I just want to inform all the audience who are with us that Shoykot didn't have a presentation here. So we haven't missed any presentation. He has basically spoken about the various issues with transesophageal echocardiography. We are running a little slow on time, delayed a bit. So I will not take any questions here. I will straight away jump to the next session. And our next session is the intra-management of COVID positive or COVID suspect patients. And we are delighted to have Dr. Shoibal Rai Choudhury here. Dr. Shoibal Rai Choudhury is a very well-known face in ACTA, and he's a senior consultant cardiac anesthesiologist. Shoibalda, my first question to you is, we have got now a lot of published guidelines for the airway management of COVID patients, but most of this do not touch on anticipated difficult airway. how do you think this patient anticipated difficult airway should be managed in the COVID pandemic?
Thank you, Rahul. See, the difficult airway plan, there are guidelines which have specifically come in Anesthesia Plan Safety Index, is Plan A, Plan B, Plan C, and Plan D. So what is the Plan A? The Plan A is the use of the video laryngoscopy with bougie and Sterilize. That's the mandatory Plan A for all suspected and confirmed cases, keeping in mind that all patients coming into the OR are suspected and confirmed patients. Plan B is, if you are not able to do that, is the supraglottic airway with small tidal volume ventilation and repeat time the video laryngoscopy with bougie and Sterilize. Plan C is, if you have failed to Plan A and Plan B, the Plan C is the 2 persons with a vice grip with use of fiber optic bronchoscopic aided intubation. So Plan A, Plan B, Plan C. Now you have come across a situation that you can't intubate and can't oxygenate a patient. Then you have to use a scalpel bougie cricothyrotomy set. So this is a planning for a difficult airway in all patients, specifically coming either the suspected patients or the confirmed patients. And believe me, now when you are taking whether RT-PCR positive, which are confirmed, RT-PCR negative, this is also suspected patients. We have to execute this plan for difficult airway.
Thank you, Shivalda. So there is a very well thought out 4-stage plan of handling difficult airway patients, and people have to follow that. My next question to you is regarding the protection of our very vital anesthesia workstation. How do we ensure that the anesthesia workstation is protected from infection?
Exactly. So, Rahul, the first is you have to cover the anesthesia workstation, anesthesia machine, the anesthesia monitors, and the anesthesia cables with transparent water-resistant plastic sheets. And this should be removed and changed after each case. First. Second is how to protect the anesthesia machine from the patient. So for that, you have to have an attachment of 2 HAMF high quality viral filters with viral filtration efficiency of more than 99.999%. One filter is attached between the endotracheal tube and the breathing circuit. Another is attached at the end of the expiratory limb of the breathing circuit at the connection to the anesthesia machine. Adding the third HAMF high quality viral filter at the end of the inspiratory limb of the breathing circuit is done. But as far as guidelines, when the anesthesia machine is not clean, then only this addition of the third filter is mandatory. Otherwise, it is not mandatory.
Thank you. One difficulty that we have across most of the theaters in the country is that we don't have active scavenging. So how, as an anesthesiologist, would you want to address this issue of exhaust gases coming out of the anesthesia workstation and polluting the OT environment?
This is a very real difficult scenario, Rahul. Actually, what you said is right. Most of the operation theaters doesn't have neither an active scavenging system or a passive scavenging system. If you have an active or passive scavenging system with a collection system, transfer system, receiving system, and disposal system, there is no issue. But now the ISA has come out with one measure that you can attach the corrugated tubing, which can be applied to the scavenging port, and that can be dipped to the bucket with containing of 1% hypochlorite solution. But keeping in mind that PPE should be used while handling this hypochlorite solution. But still, I would like to say this, you can do it. This is not a proper scavenging system. This is just a make out, bail out scavenging system. I would rather tell not to use the volatile anesthetic agents if you don't have a proper active scavenging or passive scavenging system, and convert to the total TEVA technique. So you can convert to the total TEVA technique, or you can have a corrugated tubing applied at the scavenging port, which can be dipped to the bucket with a 1% hypochlorite solution, keeping in mind a mandatory PPE should be used while handling hypochlorite solution if you don't have a proper active and passive scavenging system.
Thank you, Shivalda. I want to ask you a question which is very relevant to cardiac anesthesiologists, and this is the use of mister blowers by the surgeons during an op cap. Do you think that this might cause a spread of infection in the theater?
See, here the specific guidelines has not come into existence specifically at the mixer rules, but the American Society of Anesthesiologists, they have told, and in European, there was a discussion of European Cardiothoracic Anesthesia webinar, which they have told that there might be chances. So all people scrub inside the cases, apart from the anesthesiologist, the circulating nurse, the scrub nurse, the attending surgeons, and the primary surgeons should have a proper donning and should have a full PP, because no evidence has come out what percentage of the infection is still due to the mixer blower. So you have to take precautions, full precautions, that all these procedures, apart from the aerosol generating procedures, apart from that we know about the laparoscopic procedures, that there might be chances of spreading of the viral infections or increasing the viral load. So we have to take all personalities, healthcare personalities inside the OT have to wear full PP. That is the number one and most important factor.
Thank you. Thank you. So taking precaution is what we need to do. And then coming to a thing which cardiac anesthesiologists usually don't do is extubation of the patient right in the theater. What are the precautions that we should take if we extubate patients in the theater?
Very important. See, extubation is as grave aerosol generating procedure as intubation. So first is obviously you can't extubate a patient without a PP. First thing. Second is you have, when you are extubating, there should have to be a prophylactic antiemetic which has to be given to the patient. Adequate pain management has to be given. Extubation under transparent water resistant plastic sheet. Very important, another factor which should be kept in mind by all the anesthesiologists is please extubate the endotracheal tube with attached HEMF viral filter. After that, put the surgical mask after extubation, then put the oxygen mask over it. Try to avoid non-invasive ventilation or nebulization just after the extubation, which are also considered to be aerosol generating procedures. Whenever possibility, please try to avoid it. Extubate after proper donning. Avoid open suctioning after extubation or just during extubation. It is also an aerosol generating procedure. If needed, do a closed airway suctioning. Post extubation anesthesia, it is very important what is normal norm before COVID area. That after you extubate, you watch for some time, then you shift to the recovery room. Please, after the extubation, my humble request to all anesthesiologists should watch these patients inside OR. Please don't shift to the recovery room and then directly shift the patient to the isolated designated COVID ward or COVID ITU. So all these things are very important.
Thank you, Shobalda. And it is very important probably to take the tube out under a transparent plastic sheet. If it
I told that extubation under transparent water resistant plastic sheet is mandatory for all patients. And second, very important is please don't detach the HEMF vital filter from the endotracheal tube while you are extubating, apart from the other.
Thank you. And for cardiac anesthesiologists, what they do is they don't extubate in the theater, but they transfer the patient to the cardiac ITU. And they have to transport that patient intubated to the ITU. How to be safe when transporting these patients from OR to ITU?
See, first, Rahul, it has to be an allocated, pre-designated transfer team before I'm coming into the transport recommendation. So, allocation of the team, who are the team members for transport? It has to be clearly designated before you start up the case. There has to be a team leader, an anesthesiologist, a surgical resident or an attending resident, and a circulating nurse or the ICU nurse. So these are the members who are designated for shifting the patients from the OT to the designated ITU. So you have a team leader, anesthesiologist at the head end of the bed, surgical resident or attending at the end of the bed, circulating nurse or ICU nurse. All members should wear PP. The team leader clears the path for the transport of the patient through the designated corridor, through the designated lifts to the designated ICU. So this is the planning of the transport of the patient. Now, after this planning of the manpower, after this planning of the designated OT, designated ITU, designated corridor, and designated lifts is done. Now, what are the transport recommendations? The technical recommendations are keep the high quality HEMO viral filters attached to the endotracheal tube at all times. This one should try always. If at all that there is a possibility of disconnection of the HMA viral filter from the endotracheal tube, the endotracheal tube has to be clamped. So clamp the endotracheal tube whenever the endotracheal tube is disconnected from the HMA filter from the endotracheal tube. So you have to clamp the endotracheal tube to maintain a closed system. Better transport the patient with a designated transport ICU ventilator, or if you don't have a transport ICU ventilator, then a single-use AMBU bag attached to a designated HEMA viral filter, keeping in mind very low tidal volume during transport of the patient.
Thank you so much.
Then
that was
Rahul, there are 2 to 3 points more I am telling you. When the intubated transport process is started, first is please switch off the anesthesia machine, leave the viral filter in place with the ET tube. Then the breathing circuit can be disconnected from the filter and attached to the transport ICU filter with another HEMA viral filter attached to the end of the expiratory port. Use the closed suctioning system, if at all, before shifting you are suctioning it. And last but not the least, patient should be adequately paralyzed before you are planning to shift the patient to ICU.
Thank you so much. You covered all the points that the anesthesiologists have to take care of. It's kind of like a checklist which has to be done when transporting this patient.
Yes, yes.
Running late, but I can't help but take one question from Rongon. Dr. Rongon Kole has asked one question which is directed.
Okay.
Rongon has asked that how do you sterilize operation rooms after each case?
See, here it's very clear that when there is a COVID patient, okay, so after the COVID patient and the healthcare personnel are out of the OT, it is better to have a 30 minutes transit time. That's a door closed time. Nobody enters into the operation theater. Nobody comes out of the operation theater. Now there is nobody who is on the operation theater. We will have a 30 minutes time inside the operation theater where the operation theater, the door is closed. After the 30 minutes, there will be a time which is needed for a COVID patient sterilizing time, where it has to be sterilized with hydrogen peroxide spray with use of sodium hypochlorite solutions in it. That takes close to around 1 hour. So minimum 1.5 hour turnover time has to be there when you are having a COVID patient. And when you are having a suspected patient also, your principle of cleaning and the principle of the turnover time has to be same. So 30 minutes, there should be a door closed and nobody enters into the operation theater. After the 30 minutes, the housekeeping enters into the operation theater with a full PP, with hydrogen cleaning with hydrogen peroxide spray and with cleaning with sodium hypochlorite solution. And that takes close to minimum of 1 to 1.5 hours.
So, Dr. Dibyendu, if you can mute your mic, there's a feedback coming. Nicely, have a few topics left. I'm delighted to have Dr. Viswas Malik, who is the consultant cardiac. Viswas is a dear friend to all of us, and we are honored that he is here in this platform speaking with us. Viswas, my first question to you, and Viswas was speaking about post-operative management of cardiac patients in the cardiovascular ICU in COVID times. And my first question to you is, if I extubate a patient in the ICU, a cardiac patient, what are the necessary precautions taken at that time?
All the points have been covered nicely regarding extubation.
Viswas, 1 minute. Viswas, just 1 minute. Can you mute Dibyendu's mic, please? There's a lot of feedback coming.
I'm trying, but exchanging sometimes.
Can you ask Dibyendu by a call to mute his mic? Yeah, thank you. Viswas, please continue.
Oh, okay. So all the extubation criteria, almost all the points have been nicely covered by Sebel. Almost the same principles we are likely to follow in the ITU, but the most important part is when to extubate. So when to extubate is these patients, they are having a double whammy, means either what period we are in, whether it is 1 to 5 days of the COVID or 5 to 14 days of the COVID. So the patient is likely to have a more cytokines as a result of the cardiac surgery as well as the underlying disease. So these patients are more likely to have SIRS in the post-op period. So the extubation trial has to be given when we are sure that the patient is reasonably negative, actually more negative than the usual cardiac patient. So similarly, the aerosol generating precautions have to be taken. The closed suction has to be in place, means it has to be done preemptively. And the second thing is the high flow nasal cannula should be there because these patients are likely to require more oxygen. And if the patient is in the second week of the patient is likely to have more airway edema. So leak test has to be negative, means the patient should not have any airway edema, which can be detected by the leak test. And then if needed, we might have to give steroids in such patients to decrease the airway edema. So in addition to the precautions described by Sebel, we have to keep the patient reasonably negative, closed suction, high flow nasal cannula for oxygen, and it should be in recumbent position. It should not end with transparent sheets.
Thank you. Thank you. Now, as in the previous session, we were discussing about protecting the anesthesia workstation. I want your input on how can we protect the ICU ventilator from contamination. Is there any other thing you want to speak on?
So ideally, it has to be a designated place for the COVID patient. So like we keep the transplant patients in a cubicle. Similarly, these two at least 2 beds should be isolated and should be away from the non-COVID area, like red zones. So these ventilators should be dedicated to those patients only, for COVID patients. And after each extubation, the ventilator should be, there should be no shifting of the ventilators. That is one. And the circuit, while the patient is there, it should not be, a artificial bag should be there, and there should be no, it should be either in the standby position. Even if it is not in the standby position, the artificial lung should be attached to that ventilator and ready for that dedicated to that patient. That is one. Second, once you are sure that this patient is, and these are the patients you are likely to get reintubated again if it is the underlying disease gets progressed. So you should not take chances in such patient, and the observation period is slightly more prolonged, say 12 to 24 hours more than the routine cardiac surgery patient. And the ventilator should be dedicated to that patient, and there should be no shifting of the ventilator. And once you are sure, then the complete circuit should be fumigated, means we usually give it to the ventilator technicians, and they also, under complete PPE equipment, they sterilize the circuit.
Great. Thank you. That was very comprehensive. You touched on all the points. Now, I want to give you a scenario here. You had operated on a cardiac patient whose PCR was negative the first time, and the surgery went absolutely all right. But on the first POD, the patient mounted a temperature. Should you retest this patient with RT-PCR?
See, it's not the retesting of the specifically for the COVID. It has to be investigated as a COVID suspect for all other investigations, say complete blood counts, say liver function tests, say kidney function tests. End organ damage is likely to be more in such patients. That is one. And then still go for LDH levels, and then if needed, go for troponins. However, there will be too much of background noise. Then BNP levels for myocarditis, and the there will be some telltale signs in the form of lymphopenia. There will be some telltale signs on the X-ray chest. There will be some telltale signs on HRCT. When you combine the picture, then maybe 48 hours later, after 48 hours, you can go for antigen, that is RT-PCR, and antibody testing both.
Right, Ms. Vas.
And procalcitonin is just for bacterial infection. Means if it is more than 0.25, this means the patient is landing up in bacterial infection rather than the viral infection. And one thing more, I think the CRP should be done in all patients. We are not right now doing it, but it will be done in future. Means it should be done. CRP levels. It is not the absolute values. It will be the trends which will be important.
Right. So the important thing is not to become myopic and only stress on the COVID aspect. A cardiovascular patient post-operatively can mount a fever for multiple reasons, and the differential diagnosis has to be done. However, in the remote possibility that this patient comes out to be COVID positive, how do you plan to deal with the staff and the other patients in your cardiovascular?
So immediately it is labeled as a red zone. Means red. Means the patient goes in the designated area, COVID area. Means previously it was not COVID negative. Now we are suspecting that the patient is likely to be a COVID positive, and he goes into the red zone. That means a cubicle and a separate area and a separate ventilator, and all the precautions which are like PP, so staff designation, everything goes for a toss. Means now there will be 6 hours duties, and regarding the staff, they will be quarantine is not a possibility, but self-quarantine, they are given an option of self-quarantine till a test comes positive. Till a test comes positive or report comes negative or positive, whatever. So it will be treated as a suspect and COVID positive.
And obviously, as primary contacts of the patient, the other patients in the cardiovascular ICU also needs to be tested.
Tested, yes, for sure.
Thank you, Viswas. That was very comprehensively dealt with post-operative management in cardiovascular ICU. I have got one question which I can ask you, which has come from Dr. Kaushik Paul. He is a consultant cardiac anesthesiologist in Narayana Health Barashat unit. And Kaushik wants to ask you if you want to give Xylocard just before extubation to prevent coughing. Is there any science behind
it? It should be given. There is no doubt to decrease the aerosol generation or to decrease the cough reflex. There is a scientific rationale for giving Xylocard. It should be given.
Thank you. Thank you, Viswas. Thank you for being with us. Stay with us a bit long. If we have some questions right at the end, we'll give it back. We'll forward it to you. We go to the next segment of our panel, where we will be talking about cardiopulmonary resuscitation in COVID patients. And as we know, American Heart Association has come out with a guideline for following CPR. We have with us Dr. Ashok Verma. Dr. Ashok Verma is a dear colleague, and he's the current secretary of ACTA West Bengal. And my question to Ashok is that, as we all know that American Heart Association has come out with a guideline for providing CPR in COVID patients, do we have to do anything different? Is the guideline any different from the regular CPR guideline of age?
Yes, actually this COVID-19 is highly transmissible, particularly during resuscitation, and carries a high risk of morbidity and mortality to healthcare workers. Actually, resuscitations carry added risk to the healthcare worker. CPR actually involves many aerosol generating procedures. That is during chest compression, positive pressure ventilation, or establishment of advanced airway. All these actually the aerosol generating procedure during the CPR or resuscitation. So, and at a particular time, numerous CPR provider to work in close proximity to the patients. So many healthcare workers are together at risk. And third, and when the CPR is going on, actually this is a very high stress emergency procedure, and we are bound to happen to lapse this infection control program is lapsing during this time. We are not able to follow all the infection control protocols that particular during this time. So this AHA has come out with some adjustments to the CPR algorithm in suspected or COVID-19 patients. What are these? Actually, these are three things we have to do. We have to reduce the exposure to the healthcare workers, and we have to oxygenation and ventilations to these patients with lowering the aerosolization risk to healthcare worker. And third, we have to consider appropriateness of starting CPR and continuing for how long. So first one, how we can reduce the exposure. That is, we have to don PPE before entering the room and scene. But here, time matters because the survival decreases with every minutes of CPR and defibrillation delayed. So it will be challenging. We have to practice, but it may be easier in COVID building or COVID hospital. Everyone is already in PPE. So that may be taken care of. And we have to limit the personnel inside the room or where the CPR is going on. Only the essential people will be nearby, all other will be not. Third, AHA is telling consider mechanical CPR. I don't know if it is possible in our scenario or not, but they are considering using mechanical CPR devices for adults and adolescents who meet height and weight criteria. Third, we have to communicate COVID-19 status to any new provider coming in to help us. So that provider should know the status of that particular patient. Here, all patients are suspected or COVID-19. So next is how to prioritize oxygenation and ventilation. Use a filter. We are talking about filter. So use HEPA filter or HME viral filter for all kind of ventilations. Intubate early with a cuff tube and connect to mechanical ventilator as early as possible, not to ventilate with ambu bag. We have to connect to the ventilator as early as possible. Engage the intubator with highest chance of first pass success. So most experienced person should intubate the patient. And pause chest compression during the intubation. Consider the use of video laryngoscopy. If it is available, please use video laryngoscopy instead of normal conventional laryngoscopy. And before intubation, if you use a bag mask device, please use HEPA filter and a tight seal on the face. For adults, you may consider passive oxygenations with non-breathing face mask as alternative to bag mask device. If you don't want, you are afraid to do bag mask, you may consider non-breathing mask with 10 liter of oxygen for passive oxygenation for short duration, not for the prolonged duration. And the moment you get a chance, intubate the victim or person. If intubation delayed, consider supraglottic airway if it is available. And after connecting to the ventilator, minimize closed circuit connection. I am not telling anything to how to put this setting of ventilator because it is already told by many persons. But here, what will be the setting of the ventilator? Generally, we use ambu bag during these resuscitations. So FiO2 should be 1. Pressure control ventilations, just to generate 6 ml per kg of tidal volume, we have to see. And respiration rate in adult. It will be adult and pediatric, it will be 10, but in neonate, it will be more than or 30 per minute. And adjust PEEP because these patients are maybe in ARDS. So adjust PEEP to balance the volume and venous return of the patient during resuscitation. And after ROC attached, you can again readjust the PEEP and according to the patient conditions. And alarm, you have to modify the alarms because alarm will be either ringing on. And you have to secure the endotracheal tube to prevent accidental extubation. So these are the very important points. And third point is consider resuscitation appropriateness of starting and continuing. You have to decide which patient is which. Like someone is told more than 65 years of age, almost 100% mortality. So in that patient, you will start CPR or not. And if you start, how long to continue the CPR. So taking into the account patient's risk factor and likelihood of survival of that patient, you have to consider how long you will do the CPR or you will start CPR or not. And some other points I want to add because these proning positions are going on for these patients. So if a prone position that like Dr. Suresh sir has told, if they are doing this CPAP or BiPAP on prone position. So if suppose this patient has some cardiac arrest without any advanced airway, so try to attempt to place these patients in supine position and do the CPR. But if some patient is prone with advanced airway, don't try to place these patients to supine. Avoid turning, place defibrillation in anterior and posterior position, and you can consider CPR over T7 to T10 vertebral bodies, you can consider. I can add something, particularly you can ask the lay rescuer, how these lay rescuer, generally the cardiac arrest happens in home, and is the relative of that person is already exposed to that person. So they can consider to doing CPR, but the face mask you have to put on the victim. You have to put the face mask covering nose, mouth, and you have to wear the face mask at least before starting CPR. And here there is no mouth-to-mouth ventilation is recommended. Mouth-to-mouth ventilations. You just can do only chest compression CPR here.
Thank you, Ashok. That was very comprehensive. Is Dr. Shoykot Sengupta here? Shoykot, you are here? Yeah. So we have Dr. Navneet Mehta, a very senior member of National IACTA. Dr. Mehta is here with us, and he has a question to us in this forum. How many RT-PCR do we need to do before we take patients for cardiac surgery? Since you are taking care of the pre-anesthesia, can you please enlighten us about how many RT-PCR do we need?
I think I mentioned that during the thing. I don't think you will have a definite answer on this as on date. At least do one, but then you will have a 30% false negative. Some people are saying that within a span of 48 hours, there are some units that I would know who have started kind of doing the intermediate acuity surgeries. They are recommending within 48 hours do two, but there are very few of them. Because as I said, like even with 2 RT-PCRs which are negative, there has been evidence to show that they might be still harboring the disease and they could be still infected. So I think see, why are we so bothered? This is, you can take me, I'm little digressing, Rahul.
Yes.
If you ask surgeons or if you ask any clinicians when they order tests, and do they look at sensitivity and specificity in so much detail? And based upon that sensitivity and specificity, do they then decide what they are going to do on the patients? They do, but I don't think they get into that specifics. People are now getting into specifics because they're bothered about themselves. That is why what that huge bother is. So if you're really bothered about yourself, the only way around, till you get the jab on your deltoid, maybe in a year's time, the vaccine, the only thing that is going to save you is universal basic precautions and maybe a little more advanced PPE.
Yeah, to sum up then, Shoykot, there is currently no science evidence to actually recommend a second RT-PCR before taking a patient for surgery. That's what we can say for sure. Thank you, Dr. Mehta, for putting in your question to our forum, and I think you are happy with the answer that we have given. I will go to the next part of the panel, and which is a very important part of this panel, is the ultimate ventilatory care in patients who are not responding to mechanical ventilation, and we have to think about ECMO. We have with us Dr. Arpon Chakraborty, Senior Consultant Cardiac Anesthesiologist in Medica Hospital. Arpon is an ECMO enthusiast and a very dedicated ECMO physician. My first question to Arpon is, we do ECMO in respiratory failure all the time. What are the special concerns when we provide ECMO to COVID patients? You have to unmute yourself. we can't hear you, Arpon. Ashok, can you unmute?
Am I audible?
It's better, much better.
Yeah. So just before going to that, I just want to tell you one thing that we in Calcutta, we have 10 ECMO machines. So, and from the anecdotes which are there in the China, in the US, in Italy, that it's a prolonged course on ECMO and even on ventilators. 1 month, probably more than 1 month in the ventilator on an ECMO. So before jumping onto that ECMO, you need to know 4 things that we have informed from our ELSO guidelines group, that we have divided our centers in 4 groups. That are we running with our conventional capacity or not? If it is, we can offer ECMO at any point of time. And that is the grade 1, with centers running with conventional capacities. Okay, there is no problem, less healthcare workers are affected, you are running with your regular manpower. And on the contrary, there is grade 4, which is the crisis capacity, that you are overwhelmed with your normal regular patients, and top of that, there is a surge of patients. There is a peak of COVID patients which are coming with a lot of oxygen issues, lot of ventilator issues. And that point of time, ECMO we are not offering. So that 2 ends of this year. And in between there is a contingency type 1, tier 1 and tier 2 is there, where we can offer only ECMO to a definitive single organ failure patients. And there are some where we can offer only ECMO, but not on ECPR, not on complex veno-arterial ECMOs. So that is the rationality of use of ECMO we have to keep in mind, because it is not a ventilator, it is resource intensive and it is labor intensive. And coming to your questions, there are very few considerations of ECMO in COVID, which I want to tell you, that we perform this cannulation and decannulations as important as cannulations in the COVID patients. And we try to perform in negative pressure ICUs, but considering in that everywhere negative pressure ICU will not be there. So we are planning to perform it in the COVID cohorted areas where all the patients we are keeping in the COVID ICU, and we are performing there. And we are not taking them to the OR, or we are not taking them to cath lab. Sometimes they are required, but we are not moving that kind of patients. Second thing, we are minimizing the personal entry, and every time the highest of this senior member is going to cannulate, or senior perfusionist team is going to be there for putting the patient on ECMO, because there should not be any kind of accidents which should happen, and that causes enormous amount of blood spillage or something which you cannot control at that point of time without much aerosol generation. That has to be there. Third is this COVID thing is surprisingly coming with a very hypercoagulable state, and that is evident in the Chinese data, that is evident in different data, where they have to change the oxygenators in one ECMO run. They have changed the oxygenator maybe 3 times, somebody changed twice, and this thing. So it is better to keep a second oxygenator on a running mode to do that. If not, you better to put bigger cannulas and run it on a bigger flows, higher flows, so that your thing doesn't get clotted. And the fourth thing is what I want to stress upon. There are all of nitty-gritties are there. ECMO has a disposable part and has a non-disposable part. The consoles, the driving unit, that has to be sterilized in proper way, because you are going to use that thing on a next patient. So that is as important as your ventilators, as your anesthesia machine, that has to be sterilized, and you have to prevent all the blood spillages on a very lower manner, so that it should not, any blood should not spill over all these non-disposable circuits. So that is the thing I want to stress upon that on ECMO part.
Thank you, Arpon. Yes, we were listening to the CTS net webinar on ECMO management, and we were listening to the physicians from the Paris Hospital of Salpêtrière, which is a very well-known center for ECMO. And hypercoagulability was one of the things, and pulmonary embolism was one of the things that they were finding in ECMO patients in COVID. My question to you as a ECMO physician is that it is a very resource-intensive thing, ECMO. You need the machine, you need a lot of manpower, you need technical expertise. In between all this, how do you protect your staff who are taking care of the ECMO while the patient is on it? How do you take care?
That is a big issue actually, because I'm telling you, because this ECMO requires involvement of personnel who are not very much directly related to day-to-day ICU work. So you can motivate a nurse, you can motivate a doctor who is regularly doing the ICU duties, but it is require a much higher motivation to motivate a perfusionist to leave his OT and to assist you on that ECMO procedure. So motivation level has to be higher. And the second thing I'm telling you, the expert doffing and donning procedures has to be done with a very good simulation training of those persons who will going to do ECMO with you. There may not be any ECMO case for next 2 to 3 months, but the simulation training should go on. And probably if it is possible, you should prepare a circuit, which is on also, we prepare a circuit and keep it for 30 days if we don't use any glucose containing solutions, is because it's a closed circuit. The time has been increased to 60 days. So you can keep a circuit which is already primed, so that at any kind of emergent situation, you need not to bother all their health, because they may be occupied in other part of your operation theater, and the numbers are not that high because we are not very much accustomed to get them always at your side. So you may be only 1 or 2 persons are putting on ECMO and producing the circuits and connecting the circuits. So it is always better to have a preformed circuit and just connect it when it is required. Number 3 is that doping donning procedure has to be explained. The simulation technique has to be there. And what we have done that we always do that the monitors of the ECMO console and the monitors has to be looking towards the door of the cubicle, so that you should not go inside too much. And you stop and you restrict your samplings from the circuit. You minimize your touch with the blood, with the patient of your personnel, so that they are not getting very much exposed to this. And obviously PPE you are using, everything you are doing, that is. And the third thing is there is a big concern coming out because there are some instances they have shown there is a plasma leak, which is not very much evident nowadays with that kind of our silicon oxygenators. But if it happens, there are some procedures we do, we rush the oxygen or the fresh gas flow in a higher flow so that extra water pours down and it cleans the membrane edema. But it is not recommended to do that, because if there is a plasma leak, it is evident that there is some breach in the continuity between your blood and your gaseous surface. So you just discard it and you change the oxygenator at that point of time, so that your personnel don't get infected at all. So that is the staff safety thing you have to take in control. And the last but not the least is the decannulation. What we actually do in a very careless manner. Even the patient, if is dead, we decannulate like anything, but that you have to take care. Even decannulation from a dead body, even it has to be important, has to be taken care of, because at that point of time anybody can be infected. And decannulation of a successful decannulation also has to be taken care of. If it is taken surgically or if it is taken percutaneously, this has to be with proper donning of PPE and taking proper personal protective equipments.
Thank you, Arpan. These are very practical points, and these have to be actually made like a checklist, which all practitioners of ECMO has to follow. Thank you so much for taking us in a very comprehensive way the management of ECMO in COVID patients. We go to the last topic in our today's evening forum, evening CME, and I invite to the forum Professor Shampa Dattagupta. Professor Shampa is the head of the Department of Cardiac Anesthesia in NRS Medical College, and Professor Shampa will be talking about that dreaded thing of accidental occupational exposure of healthcare physicians. Shampadi, are you there? Dr. Shampa, can you hear me? Ashok, can you see if Dr. Shampa is there with us?
I'm not able to see her with me.
No, she's there. She's there.
Okay. Dr. Shampa, please tell us if you can hear me. Ashok, can you just call her up and
HP. She's HP actually. You can unmute HP.
HP. Okay, just wait.
Ashok, just unmute HP.
Yes, I'm doing. HP is HP 20.
Yeah, Shampadi, one moment, we'll unmute you. Capital H, capital P.
I have unmute.
Yeah. Shampadi, can you hear us? I think you have to remove your earphone. We can't hear you. Just remove your earphone. We can't hear you. Can you remove your earphone from the computer?
Hello.
We can hear you. Great.
Hello.
শুনতে পাচ্ছি আমরা।
It's okay. Don't put on that earphone. You have to remove that earphone. Remove that earphone. Disconnect it from the computer. Perfect. Thank you. Now can you hear us?
Hello.
Yeah, perfect. We can hear you.
Okay.
My first question to you is regarding accidental occupational exposure. This doctor was working in the COVID isolation area, and suddenly he had on his eyes the spillage of body fluid from a COVID patient. There was a spray of body fluid on his eyes, accidental. How do you take care of this doctor? Is there anything to do right there at that time?
A very good evening to you, everybody. At last, you have infected the doctor with the COVID. First, I want to mention that establishment of that IPC program and the Hospital Infection Control Committee is an important issue, which should be there in the hospital, which should be chaired by the senior administrator, and the representation from all the relevant discipline and the departments responsible for establishing and implementing the IPC program is very much essential to manage this type of the cases. Actually, all the persons with the history of the spills must send to the isolation, either home or to any isolation ward under the medical supervision. And if symptoms of the positive nasopharyngeal swab arise, then admission to the COVID hospital is mandatory. Now, as you are talking about the spillage, if it is only in the eye, that is different issue. But if there is spillage everywhere, maybe in the gloves, maybe in the floor, maybe in the hand, because maybe that the doctors is wearing gowns or everything may not be. So everything has to be taken care of. The most of the organic matter of the spill to be removed with the absorbent material, soaked with the disposable absorbable material, and to be kept there for 30 minutes for the proper disposal of the material. But for the eye particularly, this is to be very much careful that one should not rub the eye at that particular moment. They can wash the eye with the running water, and after that the 20-second hand washing using the hand sanitizer, having the 60% alcohol is mandatory, and the wearing glass at that particular moment after washing is adding an extra protection to that person. After that, the avoid touching of the face, eyes, and the nose must be carefully dealt with. And use the tissue for touching everything, including the coughing, and proper disposal of the tissue is important. After that, the doctors should maintain the safe hygiene and the social distancing. From the home quarantine, it is advisable to test after the 2 to 3 days for the RT-PCR. If negative, then repeat after 14 days. And regularly disinfect commonly touched item at home. And the doctor should keep in touch with healthcare personnel from any organization, and he must monitor himself or herself for the worsening symptoms or the warning signs for like breathlessness, fever, chills, hemoptysis, uneasy fatigability, or any altered sensorium. In this way, and the thing is that the place of quarantine, if it is not possible to keep a doctor with other, but if it is not possible, then must maintain the minimum 1 meter distance from the other person or the other patients in the isolation ward. And regarding the ventilation of that ward, as a doctor or for everyone, I should say that the airflow of the room should be at least 160 liters per second per patient for the natural ventilation. And if it is in the negative pressure room, that should be at least the 12 air exchange per hour in that particular room for the proper percolation of the air. And control detection of the airflow when using the mechanical ventilation of the patient if required is also should be taken care of.
What it comes
and they must be provided with the respiratory hygiene and the cough etiquette equipments. Actually, they cover the nose, the mouth, tissue, and the dispose.
Right. I think we have lost Shampadi's feed. In between, we have got a very interesting question from Dr. Shayondi. Shampadi, just come back to you. I'll come back to you. I direct this to Dr. Suresh. Dr. Suresh, if you can hear me. Dr. Shayondi Jana, he is a student of DNB Cardiac Anesthesia at Ravindranath Tagore. He has asked a very important question. What body fluid COVID positive patients are to be considered as potential source of infection other than respiratory symptoms?
Stool samples. So we're very careful of not sending stool. Two fluids that we are very afraid of is stool and respiratory samples. So everything else, blood is not contagious, so we are all right in handling blood the regular way. But stool, so we don't even send a stool routine examination. We don't send a stool for OA parasite, nothing. No testing is done, and the disposal of the stool is to be taken care of very carefully.
Thank you. Thank you. I think, Shandip, you got your answer there from Dr. Suresh. Shampadi, coming back to you, if a student or a resident doctor who's working in the COVID isolation area tests positive, how do we want to take care of that doctor or the healthcare personnel? How do we quarantine? When do we test? When do we allow him to come back to work?
It is possible if there is provision, he must be quarantined at home. Otherwise, there is facilities from the government to quarantine in the hospital also. But this is better to go to home and stay with the other members of the home, because at this particular moment they need also the psychological booster for this 14 days. This is very important to stay with the family members also. And as a doctor, the self-monitoring is possible for temperature and the respiratory symptoms for the dyspnea and those distress. so he can inform the other health personnel to serve if any emergency arises. But the dedicated and the trained healthcare worker must provide for the care of that person with well-equipped PPE and the maintaining hand hygiene when they will reach to the patient, and that 5 moments applications of the hand washing, everything must be taken care of. And at least, and this is to mention that as the doctors are different from the other patients, so they are the superior in managing this case when they are in the isolation at home. But regarding the returning back, there are two aspects we will consider. It is if the patient is symptomatic, may be confirmed or suspected for the COVID. That is one issue. Another is the patient is asymptomatic, but he is COVID positive. These two things we will consider during the returning for the work. So the patients who are symptomatic, they may be considered in two ways. Either the symptoms-based strategy can be followed, where at least 3 days or 72 hours is needed to pass. That means the resolution of the fever without any fever-reducing medication, and improvement of the respiratory symptoms if had, just like cough, shortness of breath, etc. And at least 10 days have passed since the first symptoms appeared. This is the first thing. Another is the case-based strategy. This is here the resolution of the fever should be there, and the improvement of the respiratory symptoms should be there, and the negative results of the RT-PCR for at least 2 consecutive nasopharyngeal swabs that should be collected more than 24 hours apart. That should be negative. And when this criteria will fulfill, the symptomatic suspected of COVID can join for work. Another thing is the patient with the asymptomatic but COVID positive. There also we will consider 2 strategies. One is the time-based strategy, another is the test-based strategy. Time-based strategy, 10 days after passing since the date of the first positive diagnostic test, assuming that they have not subsequently developed any symptoms since their positive test. If they develop symptoms, then the symptom-based or the test-based strategy should be used. And for the test-based strategy, in case of the asymptomatic patient, the negative results of the RT-PCR should be taken in the 2 consecutive nasopharyngeal swab with the 24 hours apart. So when these criteria will be fulfilled, then the patient can join for the work. But the thing I want to mention, Rahul, is that in our younger age, in the microbiology, we used to learn that all the virus or RNA, if unless proved otherwise. So these tests are not specific for the COVID. So if the patient has any kind of influenza or anything, so I think the individual might also go for influenza testing to return to the work. This thing I can want to add apart from this protocol which are made by the government.
Thank you, Shampadi. Thank you so much. We have finished our discussion on almost a 360-degree aspect of COVID management from the perspective of an anesthesiologist and intensivist. If you have, any one of you have any questions which remain to be answered, please put it back in the IATA West Bengal WhatsApp forum, and we will reach it. We will forward it to our specialists, our experts in the team, and we will send back the answers to you that we can issue. I give the microphone back to Ashok Verma, the Secretary of the Society, for the closure.
Hello. I just thank you all the panelists and the moderator for this beautiful session, and a special thanks to our scientific secretary, Dr. Shomi, who has made these presentations with the moderator very nicely. And I thank to our President, Madam Dr. Sampadatta Gupta, and each and every one member of our society. I just want to thank you and thank you.